Thank you very much for that, for the wonderful talk about a great initiative. You might have underestimated your own role in that whole conference as being the driving force and one of the great inspirational forces there. And I think it's a wonderful, it's a very impressive job that everybody involved has done there to try and improve emergency medicine in that region, which, as most of you probably know, are a bit less well-resourced than many parts where we come from. On that note, I will now try to move to another country in the same region, Romania, and ask Lavinia maybe what your experiences are with emergency medicine in Romania. Now, for those who do not know it, Romania has emergency medicine for over 20 years now as a specialty, and has a well-established emergency medicine system as well. Can you tell me about your experiences?
Yes, thank you. So I am an emergency medicine consultant. I was trained in Romania and currently work in France. And I think I'm very proud to talk about emergency medicine in Romania because I indeed consider it a success story in the region. So for 20 years we have a good working pre-hospital system. There is very good working in hospital system. There are emergency departments all over the country. There is an air flight system. And there is also the emergency medicine specialty with a duration of 5 years, and it's already now working for more than 10 years. But of course, and this is thanks to the very charismatic personality of Dr. Raed Arafat, who understood that in order to make change, you have to be involved in the government. But of course, there are changes and there are challenges. I would name 3 of them. The first challenge is to understand that in order to provide acute care, you don't need only to develop emergency medicine. You have to develop the system behind it. And I think there is need, and people are understanding it now in Romania, and I think they are trying to implement programs to do it. We really need to develop ICU, adult and pediatric ICU. So we will not find ourselves in the position of having 10 intubated patients in the emergency room, or to find ourselves in a shift where we have a 5-year-old child with meningococcemia who is refused by the ICU physician because he is not intubated. This is unacceptable. Also, I think there is a huge difference between the care that you can receive as a patient in a big city, in an university teaching hospital, and in a smaller city, what can we say about a village? And the third issue, which I have to address it is the drainage of doctors.
Okay, thank you very much. There was one particular point that is quite interesting. You mentioned that in order to deliver proper emergency care, is not only the emergency medical system, it's broader than that, and it was also something that I think Terry commented upon before as well. I would like to shift to Professor Petrino. What's your view on this in terms of systems and emergency medical care?
Yes, indeed. As Tatiana told you before, the EUSEM executive and other EUSEM people went around in Europe, and in particular in Eastern countries, and in particular in Serbia, because they are really active, and we had the chance to understand very well that they have the specialty, they have very good competence, but what is really lacking is the system. The system is pretty much developed in the pre-hospital, but it stops there. So there is no emergency department, or very little emergency department, and there are a lot of resources that are wasted in admitting patients in specialistic clinics. That is really inappropriate, because a patient doesn't come, you know very well that the patient doesn't come with a diagnosis, so you cannot address the patient to the cardiologist or the neurologist from the field. Different thing is in Romania, because as you said, in Romania you had a very bright doctor, that is Dr. Raed Arafat, that had the courage to enter into the dirty job of governments and to build up a wonderful emergency system. But as you say, it is not enough. The system, the emergency medical care, is not only emergency medicine. We are struggling for emergency medicine specialty because it is fundamental for our life, everyday life. But you need to have a system behind. If you don't have a system that is critical care, ICU, CCU, etc., and operating theaters, of course, our job will be useless. So it is a chain of survival also in this case.
Now, the challenges that also we face in the western parts of Europe are related to system issues. So there are some similarities there that I would like to go a bit further into. Any possible solution to this? We're talking about decision makers, we're talking about systems. Where does the opportunity lie?
Well, it is our very difficult task, but we need to bring it about, to convince. And we hope that we have very important institution in this room today, the WHO, and so probably they can be very useful in this sense, to demonstrate to governments that to invest some money. And as you said, you need to start slowly, but you need to start the change. To invest some money in changing the system, so investing in emergency medical care and in the system, in the critical care system in general, is cost effective because it reduces morbidity and mortality, first of all. So your workforce is not impacted, and because it is more appropriate. So you do not run the risk to spend money where there is not the need, for example, admitting a patient that has nothing, and you may spend this money for doing a better job on the patient that are in need, so with a good organized system. So this is the key point. The key point is to convince, invest some money. At the beginning you need to spend, but this money will come back for sure.
I would like to add also to this idea. So in order to change things, yes, you need the political will. We were discussing this morning with Tatiana. Doctors are not, many of times, not involved in the decision making or in the decision taking at the government level. But I saw it in my country through the personality of Dr. Raed Arafat. It is possible to make that change, and it was not him alone. He was able to build a team of people who helped him implement those changes. So we can wait for things to come from above, but most of times, if we really want things to be done, we have to empower ourselves to take the courage to make those changes and to speak for our communities and to speak for our patients.
Another issue that, just to throw into the group, what we just reached was a very interesting conclusion. First we talk about the differences in resources, and then the conclusion is if you have less resources, then actually that might direct more towards emergency medicine, because when there's more stress on the system, you need to be more efficient, and emergency medicine is exactly excelling at that point. Anybody like to comment on that?
I just want to tell that, in my country now it's a big problem because the young physicians don't want to choose emergency medicine. It's too hard, it's too stressful for a very low price of monthly fee. And they choose to go to Germany, of course. And for example, in my EMS today, 50% of the doctors are older than 55. Okay, and we are working pre-hospital settings. It's not easy to have 60 years and work in pre-hospital systems. And I think that I don't know. We are trying what we know, and we're trying to do best. But I think that our system will be collapsing one. If something's not changed, I don't know what will happen with us, really.
I agree with you, because actually we had the same problem a few years ago. We had openings for residency, like 50 places for emergency medicine, and we used to get 10 doctors in the hospital, 10 applications. But I think if you try to motivate them by being inspirational, which is not always easy in a busy shift or with a befitting professional and personal life. Also, what the Romanian government did in trying to keep the doctors, because there was an exodus of doctors from Romania to Western Europe. Recently, they tried to raise the salary, so they tried to diminish this, to cut this as an incentive for leaving the country. And they also try, at least in the department where I used to work, they try to engage young doctors in different activities. They send them to congresses. They try to motivate them, and they try to make the specialty more glamorous. And you will laugh, but the way of doing that was gaining public opinion by promoting a movie in Romania about the work of emergency physicians. So basically, we would work in the department with a crowd of reporters with us, seeing what we are doing and trying to promote the specialty in the country, and basically to make this specialty, which is really hard and really stressful, trying to make it more sexy. Well, it worked, because right now we have 50 residents for 50 places in that emergency department. Yeah, so it's a way of doing things.
That's a good idea. We might have to develop that one further, other places as well. A very interesting observation is that I guess that everywhere where a healthcare system in its whole fails, we feel it at the emergency department, and I think this is a very good example of that. If the same goes for the United States, where there is no funding, as hopefully will happen also in many of the countries in Europe, if it's really true that, and that's what I believe, and that's what multiple studies have shown as well, if emergency medicine is an efficient way of caring for people, then that benefits the whole healthcare system and the whole society. And in that way, even though it costs money directly, in itself is cost effective because of decreasing so many other burdens. So maybe that's a little wedge of an idea to start off with. I would like hereby then to thank the panel members and thank the audience for their attention, and see you around the conference.